Good morning, everyone. We will start the session of atrial fibrillation and use of NOACs in atrial fibrillation. First of all, I would like to thank Cardiocon team and Dr. Kamal Sharma sir for inviting me for this opportunity. And we all know whenever any academic is there, sir's name is always there first. So let us start today's session. So, sir has already described the case scenario. 78-year female, hypertensive, AF with fast ventricular rate, LV ejection fraction is 30%, and CHEST2 score is 5, HASBLEED score is 2, and normal CAG. So, I will discuss about the dabigatran. Why dabigatran is the better choice for this patient. So first of all, we will see this atrial fibrillation is the most common sustained cardiac arrhythmia, and it is seen in 1 to 2% of the general population. Major risk for this atrial fibrillation is ischemic stroke and systemic thromboembolism. AF is responsible for 15% of the ischemic stroke cases among the all age groups, and this rate increased up to 30% in people older than 80 years of age. So why dabigatran? Dabigatran is reversible, potent, competitive direct thrombin inhibitor, and unlike heparin, which can only bind free thrombin, while dabigatran is capable of binding, inhibiting both free and clot bound thrombin. So we all know dabigatran is direct thrombin inhibitor. Dosing is 110 mg BD and 150 mg BD. Elimination by 80% of renal excretion. It is a prodrug and half-life of 12 to 17 hours. So this is the first study, the RELY study, which we all know, that is the randomized evaluation of long-term anticoagulation therapy, which was done between dabigatran versus warfarin. And this study was published in renowned Journal of New England Medical Journal on September 2009. And result of this study was, we can see there is a primary outcome in which dabigatran 110 mg is non-inferior to warfarin group, whereas dabigatran 150 mg is superior than the warfarin group of people. So this is the brief about RELY trial. And in RELY trial, in inclusion criteria, we can see our patient is matching, like age is more than 75, LV ejection fraction is less than 40%, and she is having hypertension also. This was the exclusion criteria in which they took excluded the severe valvular heart disease, stroke, any condition which increases the risk of hemorrhage, creatinine clearance less than 30, liver disease, and pregnancy. And they did follow-up of 2 years. And the primary endpoint was stroke and systemic embolism, and primary safety endpoint of major bleeding, and secondary endpoint of stroke, PE, hospitalization, vascular death, and all-cause mortality. So in this study, they studied and they get the conclusion of 150 mg dabigatran significantly lower the rate of stroke and embolism, and it has similar rate of major bleeding compared to warfarin group. And in dabigatran 110 mg dose, there is a similar rate of stroke and embolism and lower rate of major bleeding. So in both doses, they are significantly reduces the risk of intracranial hemorrhage, and there is a little bit increased risk of GI bleed was there, and dyspepsia was the most common side effect observed in this study. The safety outcome, if we see dabigatran of 110 mg versus warfarin and dabigatran of 150 mg versus warfarin, we can see there is a significant reduction in the non-life-threatening and life-threatening bleeding, minor bleeding, and definitely significant reduction in the intracranial bleeding, which is seen in both dabigatran 110 mg as well as in the dabigatran 150 mg of dose. This is the another data they took from the cumulative hazard ratio for the primary outcome of stroke versus systemic embolism, in which they got the conclusion that dabigatran 150 mg is definitely better drug than warfarin, and it is a superior drug in getting the primary outcome. So we'll discuss about some trials comparing NOAC in recent data. Actually, there is no randomized trial comparing different direct oral anticoagulant in non-valvular AF, but some observational studies showing some conflict results. So this is the first meta-analysis was done between the rivaroxaban and dabigatran group, and this pooled hazard ratio for the primary as well as secondary outcome. And here, in conclusion, we can see the rivaroxaban is associated with higher risk of stroke and bleeding compared with dabigatran. So, according to that meta-analysis, dabigatran is better drug compared to rivaroxaban. In this meta-analysis, again they studied the apixaban and dabigatran, and they took the pooled hazard ratio of primary as well as in secondary outcome. And conclusion of this outcome was apixaban is associated with similar risk of stroke and bleeding compared with dabigatran. So dabigatran is equally safe drug as compared to apixaban. This is one more study published, and this is the Nexus study. That is the main aim of that study was safety, effectiveness, mortality of apixaban with vitamin K antagonist, rivaroxaban and dabigatran in oral anticoagulation in non-valvular AF. This is the observational study, and they took the outcome was safety in the form of major bleeding events leading to hospitalization and effectiveness of drug in the form of stroke and systemic thromboembolic events. So this is the cumulative incidence curve for the safety of apixaban versus dabigatran, and the result was apixaban was associated with similar safety to dabigatran. This is another cumulative incidence curve for the effectiveness for apixaban and dabigatran, and here they can got the conclusion that apixaban was associated with similar effectiveness to dabigatran. So here apixaban and dabigatran both are similar drug in the concern of safety and efficacy. This is one more study which aim to compare the risk of stroke and systemic embolism and major bleeding in patient with atrial fibrillation using dabigatran, rivaroxaban and apixaban. So if we concern the stroke and systemic thromboembolism, dabigatran was associated with superior effectiveness compared to rivaroxaban, and in the form of major bleeding, if we see the safety, again dabigatran was associated with superior safety compared with rivaroxaban. So in this study we can clearly correlate dabigatran is definitely a better drug than rivaroxaban. This is one more study done to compare the safety and effectiveness of dabigatran versus rivaroxaban and apixaban, and they took two groups, dabigatran versus rivaroxaban and dabigatran versus apixaban. In dabigatran versus rivaroxaban, they studied the first stroke and major bleeding event, and conclusion was dabigatran was associated with significantly lower major bleeding risk versus rivaroxaban, and there is no difference in stroke risk. For dabigatran versus apixaban, the sample size was limited, so they could not draw any definitive conclusion. This is another Aristophanes study which did studies of effectiveness of safety of oral anticoagulation, and according to this study, apixaban and dabigatran were associated with lower rate of major bleeding compared with warfarin, and dabigatran was associated with lower rate of major bleeding compared with rivaroxaban and similar rate of stroke or systemic thromboembolism. And here rivaroxaban was associated with higher rate of major bleeding compared with warfarin. So summary of the major trial for NOACs in stroke prevention in atrial fibrillation. This is the major trial for all these NOACs. Like for dabigatran RELY study, which results was high dose was superior and low dose was non-inferior to warfarin. Whereas in rivaroxaban Rocket AF trial, again rivaroxaban is non-inferior to vitamin K antagonist. In Aristotle trial, apixaban was non-inferior to vitamin K antagonist but superior safety than vitamin K antagonist. And for edoxaban, Engage AF trial showing non-inferiority than vitamin K antagonist. Another study was done for seeing the discontinuation risk comparison among the newly anticoagulate AF patient. In this study, they have observed there is a significant lower risk of discontinuation compared to NOAC with all these newer oral anticoagulation drug. There is some drug interaction of dabigatran we have to take care, like with P glycoprotein inhibitor as well as inducers. So these are the list of drugs I will not go in details, but these are the list of drugs which we have to check carefully whenever we are using dabigatran. And these are the some drug interaction with potential for increasing the bleeding risk when we are using dabigatran. So obviously aspirin, clopidogrel, NSAIDs, SSRIs, SNRIs, and we are not recommending to use concomitant use of unfractionated heparin and low molecular weight heparin. Okay. So this is the just shifting. Idarizumab is an antidote for dabigatran, and what the guideline, as we all know, the guideline of AF and use of oral anticoagulation. These are the guidelines, and so which NOAC to choose? Here is the table. We can see which NOAC we have to choose. So this is the summary, and dabigatran is obviously cost effective. So this is the finally why dabigatran is better choice for this type of patient, because it is superior and other NOACs is non-inferior. It is also reducing ischemic and unspecified stroke, and it is better than vitamin K antagonist and equal in safety profile with apixaban, and it is always cost effective than other NOACs. Thank you.
Privileged to be here in this fantastic conference. Thank you, Dr. Kamal Sharma. This is a very cleverly worded debate. You've put it as cost effectiveness for dabigatran and more suited for rivaroxaban and safety for apixaban. So it's a cleverly placed debate. Now, cost effectiveness is still very much gone in the current era with all the generics around. So that is, we'll keep it apart. But for this particular case, 78-year-old lady, hypertensive, atrial fibrillation, EF of 30%, body weight of 55. We've said the HASBLEED score is 5 if we consider EF 30% as heart failure, and HASBLEED score is 2. Now, what I'm going to say is rivaroxaban is probably the most suited therapy for this patient. What are we worried about? We are in this subset. We are worried about bleeding as a major issue that we want to mitigate. Stroke we want to reduce, and cardiovascular mortality, if we can reduce, that would be great. For this subset of patients, the older patients, as age increases, chances of atrial fibrillation increases, and these patients will experience more stroke. So more than 75 years of age, the risk of stroke is almost 2.32 when you compare it to less than 65 years of age. And when we talk about the number of patients, elderly patients who have been studied in the trial, probably the largest number of patients were in the rivaroxaban and Rocket AF. So when you look at the elderly patients in pivotal trial, almost 44% in Rocket AF were more than 75 years of age. So that is just like our patients. And the overall CHAD score, remember our CHAD score is 5 for this patient. Rocket AF has studied the patients with the highest risk. So here the CHAD score was 3.5, and specifically for patients more than 75 years of age, CHAD score 3.7 in Rocket AF. Compared to that, in the other trials, it was much lesser. If you again look at the older patients in these pivotal trials, mean age 79, mean CHAD score 3.7, we are talking about 44% patients being represented in Rocket AF. So that is probably almost similar to our patients. Almost half of the patients enrolled in the Rocket AF trial were elderly, and it mimics what this patient had. Age more than 75, hypertensive, and for the heart failure. So very much mimics the kind of patient we have. Our patient is very representative. Problem with older patients is we are always thinking about bleeding. What if they bleed? So many of these patients will not receive anticoagulation. In fact, this was an observational study of around 25,000 patients. When you talk about patients who are more than 75 years of age, almost 27% did not receive any kind of anticoagulation. And this is US, that fear of bleeding, we do not treat these patients with appropriate dose. So 1 in 10 patients, here we are talking about US, 1 in 10 patients in US of NOACs treated with NOACs, this is inappropriately lower dose. In India, it's going to be much larger proportion of patients who are getting inappropriately lower dose. Problem with inappropriately lower dose NOAC is it increases the risk of stroke. So patients of AF, if they are not adequately protected from stroke, if they are not protected, prescribe the right NOAC dose. What are the risk factors? Atrial enlargement, large LA is a big risk factor. The second big risk factor is off-label low NOAC dose or inappropriate lowering of dosage, which is used. Now you are very well aware what I am pertaining to when I am talking about this. And there are other risk factors. When we talk about older patients receiving NOAC, the potential underdosing is very high in apixaban because right in the beginning there were two dosages available. So people try to mitigate the risk of bleeding by using the lower dose, but it was inappropriately reduced dose. Whereas for dabigatran and rivaroxaban, it was not that. And that resulted in higher risk of stroke with apixaban with the other two drugs. So if the dose is inappropriate, whether it's inappropriately low or high or any inappropriate dose, the outcomes are not all that good for the patient. Our patients would not require NOAC dose reduction for older age alone, except for dabigatran. Since this patient is 78-year-old, at age 75 to 80 with individualized bleeding risk, if you think, then the dabigatran dose would need to be reduced. But otherwise, apixaban or rivaroxaban, we don't really need to reduce the dose for this. This is very stark. Protection from stroke in older patients is maintained even with reduced dose rivaroxaban. So this was 20,000 odd patients, more than 80 years of age with non-valvular AF, and look at the outcome. Rivaroxaban 15 milligram OD versus warfarin, whether it's when you talk about stroke or systemic embolism, it's clearly to the left side of the line of unity. Whereas with the other drugs, it is overlapping. So rivaroxaban was much better than warfarin. Protection means effective prevention of stroke. Here again, older patients, stroke and systemic embolism, when you are comparing rivaroxaban with warfarin, the stroke and systemic embolism is much less with rivaroxaban compared to with warfarin. And even older patients, net clinical benefit of rivaroxaban versus warfarin greater in older patients compared with younger patients. So here you are talking about more than 75 years of age, events avoided. It is much more prominent in older patients. So older patients need anticoagulation. They benefit much more with anticoagulation. So it is important that in order to mitigate the risk of bleeding, you don't take them off anticoagulation, but you have to give them and monitor them better. Also, the risk of major bleeding, intracerebral hemorrhage was much lesser with rivaroxaban when compared to warfarin, and that is true for virtually all the NOACs. Our patient, 78-year-old with similar score, CHA2DS2-VASc of 5, mean HASBLEED of 2. Here this was a SAPPHIRE AC study of around 2,000 patients. Major bleeding, intracerebral hemorrhage, all to the left side of unity. So it showed the safety of the drug in terms of reduction of bleeding. And older patients, again, more than 80 years of age. Here we are again talking about major bleeding, intracerebral hemorrhage, all to the left side of the line of unity. This was rivaroxaban was much safer than compared to warfarin. With bleeding in GI or total mortality, ischemic stroke, it was non-inferior to warfarin. Adverse event rates and mortality remain low in older patients treated with rivaroxaban compared to routine clinical practice, and that is also seen in this study. So we have prefer in AF and prefer in AF prolongation registry in patients with AF more than 75 years of age. Protection for elderly patients with AF is both in terms of efficacy and safety. Here we are looking at all these three drugs, rivaroxaban, dabigatran, and apixaban versus vitamin K antagonist. Again, rivaroxaban is the only drug which clearly falls on the left side of the line of unity. So rivaroxaban clearly superior to warfarin here, whereas the other two, it was non-inferior. So for our patient, what does it mean? We need to individualize therapy for this patient, find the best drug possible for this patient. And it's not like patthar ki lakir that once you've given a drug forever, the rest of the life it is going to be like that. You may need to periodically revisit what is happening to her, whether the creatinine is bumping up, whether you need to change the dose, whether you need to shift the patient from one drug to other. We need to individualize therapy and do whatever is best for the patient. This patient, we need to carefully consider her age, frailty, that is an important thing. We have to think of frailty index. It should come into our practice again. And comorbidity when selecting an anticoagulant and its dose. Overall protection of patients with complex comorbidities like this patient in the real world setting, probably we have a great amount of data with rivaroxaban compared to others. Thank you very much. I'll stop.
Thank you for the kind introduction, and thank you, Kamal. It's a pleasure, always pleasure and privilege to be here. Last 5 years that I have been participating in this meeting. Well, Ajay has made my job very simple. You guys have already read the case. I have also highlighted all that we're going to talk upon, and I'm going to try and show you how to put that one. Okay. Yeah. Okay. I'm going to show you that apixaban is not only the safest, as also, it's a pleasure, always pleasure and privilege to be here. Last 5 years that I have been participating in this meeting. Well, Ajay has made my job very simple. You guys have already read the case. I have also highlighted all that we're going to talk upon, and I'm going to try and show you how to put that one. Show you that it is not only the safest but also effective in this very elderly, frail, low body weight person who does not have coronary artery disease and of course does not have renal function CKD. That is on the basis that the HASBLEED is 2 and the CHADS2-ASC is of course very high. So you need safety, all right, but the only two HASBLEED score points are hypertension and age, and there is no abnormal renal function here, right? By the way, I'm going to not indulge in homeopathy like what he said. The whole world does. This is a very strong message that here you will use a 5 milligram BID dose. How do you decide the dose? As it was in the Aristotle trial, 2 out of 3 ABC criteria, you would go for the lower dose. Here, to have safety as well as effectiveness, you're going to use a high dose because there is just one body weight which is lower. Now let us look at Aristotle trial here itself. Yeah, the usual inclusion criteria, randomized trial, and what is it? Comparison with warfarin in a therapeutic range. That's important. Which cleverly our man hid it from you. That is, Ajay hid it from you. And the mean CHADS2 score, there was a good 30% patients which fit our population out here, and the TTR 62%. And look at this. Somehow Tushar Bhai tried to confuse you by saying that I'm trying to tell you that apixaban compared to warfarin is superior in terms of the primary efficacy endpoint, in terms of preventing stroke and systemic embolism, as also superior in terms of preventing major bleeding. 21% relative risk reduction there and 31% relative risk reduction here. And importantly, at this dose, it is preventing mortality, the hardest endpoint too, though it was a secondary endpoint here. So, as far as this is concerned, and that same consistent effect, you go by age, it is still retained, and you see the point estimate to the left. Okay. वो नहीं चलेगा, इधर चलेगा. हाँ. So see the point estimate, the same, yeah, for major bleeding as well as efficacy. You see in the elderly, point estimates go, there is superiority here even for both these endpoints. And that consistent effect, our patient is on the verge of 80, 78, still maintained in the 13% of the population in Aristotle trial. As also, look at the dose wise. If you go by the dose criteria that I told you, the low dose, our patient deserves a high dose, but even for in the Aristotle trial, for the low dose, the point estimates are favorable. That's what I'm, no p-value for interaction, not significant, as efficacious in a low dose. And this is what Ajay Bhai hit from you. Look at the comparator arm in rivaroxaban trials out there. The TTR is the lowest of all the things, 55% time spent in the therapeutic range, whereas with Aristotle it is 62.2%. So that is what we are comparing here. We have to compare apples and oranges, but head-to-head comparisons we can't do amongst trials, and that's what is a disclaimer in red that I give you right at the beginning. And the common USP for all the three agents used in the right dose would be decreasing intracranial hemorrhage. So the vertical bars, all three are better than warfarin. We are comparing with warfarin, but the nice endpoints that Ajay showed you across the board, whatever the dose be, better with apixaban. And also, he told you a large chunk of the population. Here, look at the age more than 75. Actually, by numbers, you see Aristotle, by far the largest. It was 18,000 plus patients. So the percentages, don't go by percentages, look at the absolute numbers. Age more than 75 in the third row out there, in the third column out there, 5,678, the absolute numbers more. And then in the elderly, again look at the Aristotle trial itself, and what do you find? And all the four trials, again the point estimates, you look here, favorable for efficacy, as also favorable for bleeding. And look at the dabigatran, which was favorable for stroke prevention. For bleeding, you just can't use that 150 milligram dose. It is actually will cause more bleeding. And that is the same thing in a meta-analysis, age-wise meta-analysis of individual NOACs compared to warfarin. What do you see? Apixaban point estimates for stroke efficacy shown in the yellow, as well as, shown in the blue, as well as shown in the red, everywhere across the thing. Major bleeding, stroke embolism and intracranial hemorrhage, everywhere the superiority is what we see. Now look at this. Now, group of experts from Europe, including Gregory Lipp, the biggest guy who gave the guidelines how to use NOACs. Now, Hans Dieter, the first author, they are trying to tell you how to choose a particular agent. And what is the expert recommendation? I am no expert out here. Expert recommendation for an elderly population more than 75 years age, first choice, apixaban, 5 milligram twice daily, right? And again, the international consensus validation of the FORTA label. What is the FORTA label out here? FORTA is fit for the aged classification. And where do you see apixaban stands? At class of evidence, level of recommendation A. On the basis of evidence they come out with. And apixaban is indispensable for the elderly. Indispensable. Yes, all the other three molecules are also shown. Dabigatran with an asterisk to go on your lower dose there, and that's what it is. So having said that, let us look at the real world. Now it is always, I will always twist and tell you what is good in the real world, because real world data is all observational study. You got to look at the disclosures of the guys who are doing these studies, and but yet there is the same Aristophan study that Dr. Tushar Bhai alluded to. And you look at in that same study, in the older population, apixaban, and this is a large study, mind you, it's about 2 lakh people, and out of this 88,000 odd patients are more than 75 years of age. And what do you see there? You see that apixaban versus dabigatran, you see that stroke systolic embolism is higher, 32%, and major bleeding, risk reduction is 32% with apixaban versus dabigatran, and major bleeding reduction 26%. And also against rivaroxaban, you find the same efficacy out here. Stroke and systemic embolism down by 23%, and major bleeding down by 47%. So also this other observational study, again all these are from database of, and what have they done? They have just tried to look at the real close competition, that is rivaroxaban, and rivaroxaban versus dabigatran. The patient numbers here in that database 5,81,000, and they first looked at the standard dose and look at the major ischemic stroke hemorrhagic event, and you find that rivaroxaban is associated with a 13% higher risk compared to apixaban in this large database. Then you look at the low dose of rivaroxaban, reduced dose, and a good 23% of patients in both arms were on low dose. The low dose given according to the correct way, right? And in the real world, in the Medicare database of 1,34,000 odd patients, and rivaroxaban is associated, mind you, even in the lower dose, with a 28% high risk compared to apixaban. Now this is not relevant, but the GI bleeds are the commonest, and that's when our elderly people start getting GI bleeds, yes. But GI bleeds wise, look at both the societies, the ESC guidelines as well as the GI disorder guidelines together, the gastrointestinal bleeding. If at all, as a class 2A recommendation in 2016 itself, in patients at high risk of GI bleeding, a VKA, you may even choose a VKA, but if you have to choose a NOAC, do not choose these, that is dabigatran 150, rivaroxaban 20 or edoxaban 60. That's what is the class 2A recommendation. So in summary, I would say that apixaban 5 milligram BID on the basis of evidence, again the evidence will never be RCTs. The only RCT evidence are all these three trials that we talked about. Apixaban, mind you, for this patient also is safest and efficacious in a dose of, for this elderly frail patient, is the safest but efficacious for our elderly patient. The benefits of apixaban versus warfarin have been consistent in patients with AF regardless of age, and owing to the higher risk at the older age, the absolute benefits, which means we take into account the efficacy as well as the bleeding, are greater in the elderly for apixaban. You saw the point estimates all to the left, and effectiveness of safety of oral anticoagulants in elderly patient in real world with atrial fibrillation is also consistent with this RCT data, and that the results are consistent even when our patient grows old and goes over the age of 80 years. That's when she would, however, require a dose reduction to 2.5 milligram BID. So having said that, let's be ready for the discussion. Thank you.